This lecture is being brought to you in part by the generous gifts of these sponsors.
Well, good evening to you all.
Good evening.
Ken, Dr. Ford, thank you so much for inviting me down here, and I've really enjoyed getting to know you. It's been a terrific experience. And Michelle Bowers, I don't know if she can, oh, there she is back there. Michelle, thank you for your professionalism in getting me down here in one piece. I'm not an American, I'm a foreigner. I'm Canadian, and it's quite a treat to get across your border these days. Well, we have a little bit of a history here in Pensacola. Some of you may know this. We had a tripartite deal. We were down here for over a year working with the Pensacola Fire Department, Athletes Performance, as they were formerly known. It's now Exos, and the Andrews Institute. And in working with the firefighters, we measured them doing real firefighting tasks, for example, breaching a door, piking open an elevator to get people out, chopping holes in roofs of buildings. We spent over $500,000 documenting the stresses on the spine and the hips, and etc. And we did various training studies as well, and we found how important it was for the transference of what you do in the training room to get it out onto the fire ground. And poor coaching causes a lot of trouble. It isn't just a matter of doing the exercise and thinking you're going to be a more competent firefighter with less risk of injury out there. Competent coaching matters. The way that we quantified movement and all of the tools that are commercially available to measure movement, it turned out you had to pretty much mimic the speeds and loads that these men and women utilize on the job to be able to predict those who would and would not do well physically. Anyway, that was just a little bit of an intro to our work here in Pensacola. Well, that's the outline for this evening. The basic supposition is there's no such thing as nonspecific back pain. It's not in people's heads. Pain is not normal. There is a cause. So I'll talk a little bit about some myths, how to assess, removing your pain triggers, and then building a pain-free foundation. I'll start with this quote from the very famous Czech neurologist, Dr. Karel Levitt. The first task for the physician or the clinician is to show the patient the cause of their pain. Well, typically, not always, but typically, the patient gets 10 or 15 minutes with the medic who has no chance to probe and provoke the pain mechanism so they understand it and reach a precise diagnosis. So they're left giving the patient an analgesic, a piece of paper with some exercises that have just as much a chance of hurting their back as it does of helping. Or worse yet, they tell the person, "We don't know your pain, it must be in your head." Have you ever heard of anyone who has nonspecific head pain or nonspecific leg pain? Why do we put up with this nonspecific back pain? Degenerative disc disease, there's no such thing. Could you imagine going to your mother-in-law who's got a few years under her belt and a wrinkle or two on her face and saying, "Hi, Mom, I see you've got degenerative face disease." What an awful, terrible thing to say. If you want to give someone a psychosocial disorder, tell them they have a disease. There's no such thing as a disc disease. They're getting a little bit older. So here is a picture of a poor soul who was declared by the radiologist, who never saw them, but they looked at the picture and they said, "You've got degenerative disc disease." And the patient came to see me and said, "Oh, I've got a disease, I'm only going to get worse." And I said, "No, sir, actually you're going to grow out of that. And that is not a disease. That is a fracture called a Schmorl's node, and around that is a pocket of edema, which is an inflammatory process, and that hurts. The disc is now a bit flat, there's a little bit of a bulge there, etc." But with providing provocative testing, we learned very quickly that they had no pain if the spine was in a neutral stacked position. But when they flexed or extended the spine, it triggered pain. So how simple it was to teach them to bend over with a hip hinge rather than bending their spine, which no one showed them. So instead of having degenerative disc disease, they got a diagnosis of, you have your pain triggered by flexion intolerance. Now they have a rather precise guide of what not to do and what to do. Well, where does our science come from to have a foundation for some of these crass opinions that I have? We have 4 pillars of evidence. I'll just go through them one at a time. So we have an in vitro laboratory. Don't forget to turn that back on again when you leave. We have an in vitro laboratory. Sorry. Didn't mean to interrupt. We have an in vitro laboratory where we take real spines. I hope you've all signed your organ donor cards on your driver's licenses. And we create the injuries. So we have a one-to-one match. We know very precisely what causes a herniated disc or a disc bulge or an end plate fracture or torn ligaments or whatever it is. Then we do CT scans, X-rays, and we do microdissections. So we know exactly, once again, what those specific loads did and how they are evidenced on various images. Then we have an in vivo lab where we take real live people. Some of these pictures are historic now, and we use techniques to measure the stress concentration inside their bodies. For example, there was a study done on elliptical trainers, and if you follow the reaction of people to working on an elliptical trainer, some will say, you know, that helps my back. And then the next person says, oh, that really makes my back feel sick. And what are the variables that cause the tipping point? As it turns out, one of the more dominant ones is hip mobility. So if you have a lot of hip mobility, the elliptical trainer is very gluteal centric. It really works the gluteal muscles much more than, say, going for a walk. You may have a need to do that. But if you have mobile hips, the hips move and it really doesn't stress the spine. But if you have tighter hips, the restrictions in the hips go right into the spine and the spine starts to move, causing cumulative stress and is linked to pain. But there's one of your great gold medalists from the Olympics, a world-class strongman competitor. She won the world IPF. Anyway, these are some of the patients that come. And then we build a virtual spine. So we might start with images such as MRs or CTs, and we serially stack those to create that person's spine. So there's a spine of one of my graduate students, and we're measuring spine motion so that we drive the virtual spine, which allows us to measure the stresses in the discs and the ligaments, the passive tissues. And then as with their brain, they activate their muscles, we sense those patterns and drive their virtual muscles. Then we're able to create a stress map and see where the stress concentrations are, and then we measure spine stability. So some of you have heard of core stability, but there's very few institutions in the world that actually measure it. So how do all these hand wavers know what is spine stability, what is a stabilization exercise, and that kind of thing? The next level of evidence is the clinic. So we get very disabled backs all the way through to some of the best performers in the world and measure their way of creating these very athletic patterns, either with or without back injury. I'll use this quite famous quote from Vince Lombardi: "Every man is a volume if you know how to read him." Back pain forms syndromes. Things cluster together. So when you see one sign in a patient, if you know what the other ones are that form a cluster, you get wise and can converge on a diagnosis much more quickly. It may very well be that they have a social issue. I had a patient not too long ago, and I was trying to understand why she wasn't going out and doing her walks, which were part of the prescription. And then after a while, she told me, I can't do that. It's too dangerous for me to go out at night. And if I didn't know that, I wouldn't understand the impediment of why she wasn't doing her exercises. So these are things that when you find out and read them off a patient, you become so much more effective. The final bit in the evidence is then, now it's time to put our money where our mouth is. Let's field test it. So I told you the story with the firefighters here in Pensacola. We work with various police forces, the military, numerous sports teams, and different occupational groups to see if the interventions actually work or not. Well, this is the book that Ken mentioned. So we're just going to read through a few chapters now. These are just samples. But here's a common question that I'll get from patients. Oh, my mother had back pain. I've got it. I've got degenerative disc disease. Is it only going to get worse? And I said, well, if it's a discogenic category of back pain and you're 30 years old, you won't retire with this. In fact, you will grow out of this type of pain. Some docs say, oh, if you've got back pain, go to Pilates class. Well, the fact of the matter is that some of those exercises have just as much chance of replicating your back pain as it does of curing it. It's a crapshoot. So it's much more scientific than that. You've got to be quite precise on the exercises that you're prescribing and making sure they're not mimicking their specific pain trigger and they're actually building the foundation that they need that they're currently deficit in. There are some institutes that say, send us your MRI and we'll decide whether we're going to operate on you. Well, it doesn't work that way. I believe that no radiologist with back pain or with a back pain patient should write a radiology report. Now, I have no issue with cancer patients and they're trying to find a tumor and that kind of thing. That's good usage of MRI. But with a back pain patient, when the radiologist looks at the anatomy and starts to report on the anatomy, it has nothing really to do with whether or not that is the cause of the person's back pain. When an injury to the back first occurs, you may or may not see it on the MRI, but the function of that joint changes. And in 2 or 3 years, a little bit of arthritis will start to grow around the facet joints, and they may remark on that, and that is the unstable phase. There's micro movements at the joint that are triggering pain. But in another 10 years or so, the good news is all of that has gristled and stiffened out. The pain is gone, but the MRI looks horrible. Would you operate on that joint, or would you operate on the one above now that is responsible for all the motion when that original injured one has now gristled up? So these are myths that result in a bit of heartache, I'm afraid. Okay, well, let's move on now. We'll skip a few chapters. And if the medical system is not set up to provide a precise diagnosis to the patient, because of the political reason is they don't have 3 hours. It takes me 3, if I do a very thorough assessment of a back, I spend 3 hours to go through the mechanics, the neurology, the social situation, the history. That's, if you want a precise diagnosis, that's the reality of it. So, can I guide a patient to do a self-assessment? So let's consider that idea for just a moment. Now, there are many tissue-based differential diagnoses. The pain might be coming from a disc, a sacroiliac joint, a facet. We can get close to the tissues after that level of assessment, but you never will, nor will it matter to you to know what the precise bioanatomical pain trigger is. However, if you could understand which motions, postures, and loads make your pain increase and which ones take your pain away, that would be the most valuable thing you could know. So there are what docs call red flags, things that are sinister and nasty and aren't good to have. Always start this process by seeing your clinician to get cleared to make sure you don't have one of these things. But I'm going to add one, or actually a couple more, but focus on this bottom one. If you cannot find a motion, a posture, or a load that takes your pain away or makes it worse, you don't have mechanical back pain. You want to go back to your clinician now, and we've found numerous tumors, infections, and nasty things because the person didn't respond to those. But if you have mechanical back pain, you will be able to find a motion, a posture, or a load that makes you worse, and you must avoid those to desensitize, and ones that you can tolerate and you should build on as part of your therapy. So let's start with a supposition. Exercise reduces pain, just a supposition. Well, I'm going to show you a mechanism in just a minute that repeated spine flexion, that means bending your spine over and over and over again, sitting at the computer for 8 hours, doing this with your cell phone, under a certain amount of load will create a little bit of a breach or a delamination in the collagen fibers of the disc. See, the disc of your spine is not a ball and socket joint. It's not made to work like a shoulder or a hip and through the range of motion back and forth. But if you stop that flexion under load mechanism, the hydraulic pressure is reduced. So you folks are Floridians, so I'm going to use an orange seed example. If I had an orange seed and I was going to pinch it between my finger and thumb, and I biased the pressure on this one side, the orange seed would go out that way every single time. But if I drove the thrust line right down the middle, it would hold it steady. So if I flex forward over and over and over again, hydraulically I create an effort and it will work the nucleus posteriorly. I'll show you what I mean in just a moment. But once again, if I was to use my hips and move from the hips, that hydraulic pressure would be negated. We can prove to you that quite often will cause the bulge to shrink, and the open fissure, I'll explain that, gristles, and you end up reducing the pain. So in each one of these, there are 3 elements. We will assess, interpret your history, purposefully provoke the pain so we understand the mechanism, do the opposite to take the pain away. Now we're doubly confident that we understand the mechanism, and then we don't prescribe exercise. The first thing is remove the cause. Allow the pain trigger to desensitize. Build a person that is now receptive to exercise, and then build a program that isn't Pilates or yoga or anything else. It contains elements of what they need to build a pain-free foundation. So let me give you an example now. Let's see if we can find your pain trigger. And in back mechanics, of course, I've written clinical textbooks for clinicians that are big, thick things, and you wouldn't want to read it. But for the lay person, can we at least get it down to yes, flexion causes your pain, or extension, or here's a compressive load. Just go up on your toes and do that. And if that created a pain trigger, a little bit of compression causes your back pain. So if we were to start this way, have the patient or yourself sit on a stool. Grab the side of the stool and pull upwards, which compresses the back. Most people will say, yeah, that doesn't cause pain. A few people will say it will. And then we say, slouch down and repeat. And some will say, or if they say, that increases my pain, you've just identified that bending forward and flexing the spine is a pain trigger. Now observe the neck. The posture of the neck determines the tension of the cord and the lumbar roots in the lumbar spine. Some people who have cord tension, when you say, now flex your neck, oh, my right toe just went on fire. My right toe just went on fire, and yet when I lift my head up, my pain went away. So we've just proved that it's the tension, or we have the opposite, where that takes the pain away on the person, and that causes the pain. That throws a lot of clinicians. Usually, as they bend their neck forward, that's called a neural underhook. There's the offense. It might be a little bit of arthritic bone. It might be a bulging disc. But when they look down, it pulls the nerve root off the pain, whatever it is. And then when they look up, it drops their head down. And you can see this usually a mile away. If a 7-foot-tall NBA player comes in, you can see it. They're walking like this. They're walking like this. And they've been told they're a psychosocial nutcase, walking around like this. And you'll see it in their eyes. I'll do something clandestine to get them to look up, and you can see it. Oh, that hurts, doc. That hurts in my toe or down my leg. It's just the doc didn't understand that they had an underhook on that particular nerve root. So I'm going to run a little movie. There's many of these models that are made from our documentation of these. So if you bend forward under a certain amount of load, like say you've been really sloppy at the gym doing deadlifts or power cleans or something where you're under load and you've kept bending your spine forward over and over, the nuclear gel in the middle of the nucleus, these collagen fibers that form the disc are adhered together with a ground substance. You keep moving and they soften. And with the pressure of whatever the load was that you were picking up, they will delaminate and the gel will come out the back. Now just watch. I'm going to run this movie. And watch. See how I bent forward? You see the gel come out the back? That's the nerve root. Now this time I'm going to drive the force straight down. Did you see how it didn't come out? So if you're flexed forward, it pushes the gel out the back, like the orange seed going one way. But if you keep upright and you bend over through the hips, in other words, you behave like a weightlifter, zero hydraulic pressure. Do you want me to play that again? Watch. The first time, I'm going to squeeze it and bend it forward. This is exactly there. Now that can happen through sitting at the computer too long. Now I'm going to squeeze it and drive the thrust line straight down, but not allow it to flex. The disc squishes a bit, but the gel does not come out through the fissure. Over time, if you stop doing that, that fissure will gristle and it will harden up. And now you're bulletproof once again. The gel won't come out anymore. Well, here's another kind of a pain trigger. Just observe me for a second. Now, would I do this to an old 90 or 85-year-old osteoporotic person? No, I wouldn't. But for the average person, this is a 1.5 times body weight. I'll just go up on my heels and boom. Now I might say, oh, yep, my right toe just went on fire. Or that triggered back pain. Now, push your fingers out. Watch. See what I did? I turned on my abdominal wall, which acts as a bit of a brace. And then we repeat. Oh, doc, you're magical. You just took my pain away. No, I didn't. You had a little micro movement, or you couldn't tolerate the, well, let's just assume now it's a micro movement. We put a girdle around it, and we engineered out the micro movement. It made you better. Or you might say, you know what? That hurt. That made it even worse. That means you can't tolerate the compressive cost of doing a brace. Let's try something else. Externally rotate. Looks like most of you are old enough to remember the good old days of hitchhiking. Now watch. I'm going to pull down into, that's a shrug. I'm going to anti-shrug. Let my belly go. Now try it. Oh yeah, that's the secret sauce. So do you see how we'll create the pain and then play with different strategies to see what works for you? And what works for you will hurt you. Do you follow? So we guide you through converging on what will work for you. So you identify your pain trigger. We take you through a series of these, and then you identify what takes your pain away. Now, some of you won't feel confident doing this with yourself. Great, take it to your clinician, your physio, your chiro, or your trainer, or whoever, and they will be able to coach you through it. So the next stage, now you've understood very precisely the motions, the postures, and the loads that cause your pain and which take them away. So how do you then proceed? Well, you may discover that a certain amount of abdominal bracing may help or it may hurt. But if it helps, you learn to tune it now. Not too much and not too little. It's tuning. And we would take you through a series of drills there. And then we get into the movement tools. Well, some people might say, you know, the last time I had an acute attack was I was bending over and brushing my teeth. Aha. Let's teach a hip hinge. Put your hands on your thighs, just observe. Slide your hands down. Now grab your knees hard, and now you're not going to lift with your back. You grab your knees hard. Watch, this is a shrug. There's an anti-shrug. Now I tune my back. There's a flexed spine, an extended spine. Find the position that just took your pain away. Anti-shrug. Now this is the magic. Don't lift with your back. Pull your hips through. You stiffened your back into no pain, and now you pull your hips through. Everyone get that? Good. Stand up. So this is a Simon Says thing. Let me coach you through this. Folks, please, I need your attention. We got to get through this. Watch. I want you to sniff a bit of air to stiffen. Or just watch. Just do that. Nice. Put your hands on the front of your thighs, slide them down, and every good American knows how to play shortstop. Go play shortstop. Now, don't have your hands like that on your knees, around your knees. Now, carry as much weight down your arms as you can. Now, some of you are falling back on your heels. Watch, leaning tower. Lean tower forward on your ankles. Nice! Boy, you're beautiful. Now, your knees should be over the balls of your toes. Some of you need to pull your knees back. Beautiful. Now, anti-shrug. Push down and pull your hips through. There you go. So those of you who've had the experience of brushing your teeth and someone putting a knife into your back, you can learn to engineer that out as a pain trigger. Some of you have heard, oh, I threw my back out picking up a pencil, or sneezing. If you sneeze like this, whew, I'll say, good, you deserved your pain. Now, it wasn't a nasty thing to say, but it shocks the person to know they were in control. Instead, next time, if you've had that kind of a pain trigger, sneeze upwards. Whew! And now you've decreased that hydraulic effort posteriorly, if that was your pain trigger. Have a seat. So now, isn't that interesting? Folks, I just showed you the hip hinge. And what did you do? Most of you just collapsed into your chair. All you then had to do was to do what I just showed you. So now that is the spine hygiene. I've given you a movement tool. I've now shown you how to get on and off the toilet, in and out of your chair, how to brush your teeth. You get what I'm saying? Morph that into your daily patterns. And anyway, so that's what spine hygiene is, customized for you. Everyone, when they come in, I'll say, do you mind taking your shoes off? I couldn't care less. I really just wanted to see them move. So when I see them move and I determine that bending forward causes their pain, do you see that my therapy won't have a chance, nor will anyone else's, until you teach them to tie their shoe by avoiding that pain trigger. Put your foot up. Take your hips to the target. See what the secret was? Take your hips down to the target, and now you avoided picking the scab, sensitizing your back pain. You put $1 in the bank instead of stealing one out. Then we move on to work technique. This is called the archer's bow. Consider, in archery, you push on the bow, you pull on the arrow. To lift that block, you push on this support, you pull on the block, and you've just deloaded and taken out that pain trigger. So those are just some examples. Well, now let's move on to the third element and create a foundation for pain-free movement. We didn't invent any of these exercises. What we did was evaluate and assess many different spine stabilization exercises, and we had to choose the ones that were the very best at sparing your spine of load while guaranteeing spine stability. What it turned out to be was 3 exercises for the front, the sides, and the back. And the very best for the front was this modified curl up. Do not flatten your back to the floor like you've been taught in Pilates class. That stresses the back. Instead, preserve the natural curve. Put your hands, palms down, under your back and support the curve. Now, some of you will have sore shoulders or a torn up rotator cuff. Well, you better put that hand on your tummy and fold a towel in half. Or be creative. Put something under your low back. And then you lift your head and neck 1/2 inch. That's all, 1/2 inch. And hold that for 10 seconds. Avoid this. For the sides, the family of side bridge exercises turned out to be the best. It challenges quadratus lumborum, latissimus dorsi, the oblique wall, exactly what you need for the side guy wire system. Some of you, that's too aggressive. You may have to start just leaning up against a wall, stiffening and breathing as she's demonstrating there. For the back, it turned out to be what we called the bird dog family of exercises. It may just start with simply lifting one hand. But before you start, posture your spine to obtain the neutral curves. That is the least stressed position that your back can be in. You're preparing it to receive load. And then start outstretching one arm. And as you graduate, one leg. But eventually, you'll get to the full bird dog, holding opposite arm and opposite leg for about 10 seconds, and then you sweep the floor. Why? When we measured with near-infrared spectroscopy, we measured that the muscles go into oxygen depletion because the muscle contraction clamps down on the capillary bed. If you want to give yourself muscle cramps together with your back pain, hold it for 20 seconds. So that's why the science showed a 10-second hold, sweep the floor just to allow blood perfusion, and do it again. So all of these things sound so simple, but it's not rocket science, but a lot of rocket science went into converging down to such simplicity. Well, some of you will have had knee replacement, hip replacement. Do it on a chair. So you work with what a patient has. Anyway, you're starting to get the idea. Now, you have to walk to have a healthy back. There is a muscle, a primary spine stabilizer called a quadratus lumborum that works up either side of your spine. People say, well, what's the big deal with core stability? Well, I'll prove to you, you can't walk if you don't have core stability. If you go to the Children's Neurological Hospital, you'll find some little kid who has a paralyzed quadratus lumborum, one muscle on the side, the core. They can't walk. They walk like this. When they get stance on this and then swing with this leg, they're fine. But when they stand on this leg, the pelvic platform falls away. So they walk like this because they're unable to act. That's how important that lateral core control is. Now, does deadlifting fix that? Does Olympic lifting fix that? No, every single one of those exercises are done with 2 feet on the ground. The only time you challenge that frontal plane core stability is walking. It's non-negotiable. When you get that, you can do a suitcase carry a kettlebell or do a farmer's walk. This isn't heavy load stuff, it's very light. But here's some more science for you. If you just go for 1 walk a day, good, you deserve your pain. The healthiest thing you can do is interval train it. If you want to make your back sore, go for a big long walk every day. You'd be far wiser to interval train it in small, short, tolerable intervals. The more tender the back, we will have some patients, every 20 minutes you get out of the chair and you walk 5 steps. That's where they will start. But for most people, it would be much wiser, do a 20-minute walk for breakfast, lunch, and dinner. Far more healthful. Now you've accumulated an hour's good walking. Now, if you walk like this, you would be so much better if you could swing your arms about the shoulders, and it's a bit more of a military walk. Now, it doesn't have to be totally soldier-like, but there's a reason why you walk swinging your arms about the shoulders. Back pain makes your back loose and freezes your shoulders when you're in pain. But if you can liberate your shoulders, you store and recover elastic energy. So when I walk like this, I get a natural stretch across this right upper quarter and across the glute and down the leg on the other side. Swinging the arms about the shoulders fails to get this. So do you see why corrective walking matters? It matters the way you walk. Get rid of the sandals, put on a good pair of walking shoes, walk faster for 20 minutes 3 times a day. So not that, but that. Well, we're into the last little stage now. It's time to fine-tune the machine. Add a little bit more pulling power. So the TRX pulls is a magnificent exercise. There's 0 shear load on the back. The feet are on the floor. Do you realize that this is compression on the back and this is shear load? Shear load causes pain triggers in a lot of people. But when I do a push-up, there's no... I won't do a push-up. Or a pull, there's no shear load working my back. It's very tolerable for a lot of people. But if I bent forward and picked up a load, do you see how that's a cantilevered beam? That is causing a shear load through the back. So you can build a lot of strength if you know how to create what's called, from an engineering point of view, a 3-point bend on the back. Well, there is, I'm joining a lot of you with retiring and getting a little bit of a Q-tip myself on the top here. I'm much more interested in the stenosis types of older spine pain triggers. Here was a patient who came to see me, and within 4 minutes, he was upright like that. What did I do? A little bit of a thoracic spine stretch. Now, we could start and go down on the knees, and you push 2 pounds through each hand, through each elbow into my supporting leg. And then don't push down on them. Just the patient pushes 2 pounds for 10 seconds. At 10 seconds, they release and the elbows come forward a little bit. In other words, it looks like this. You push down. After 10 seconds, you relax and the elbows come forward. Oh, you just got a little bit of a lift. Well, you know, I'm not there all the time. You teach them how to do it on a chair. So they push for 10 seconds with their elbows, and then after 10 seconds, they pull their buttocks back towards their heels. Do you see the difference? How they've pulled their... And now they do another cycle for 10 seconds. Well, he didn't have knees to do that. So instead, I did it standing. There's my arm under his elbows. He pushed down into me for 10 seconds. He relaxed. I lifted his elbows a little bit more. Do you see how he's now higher? 3 cycles of that, and now he's standing like that. So there's just an example. Is it going to work for all of you? No, of course not. But it'll work for some of you. So I'm just giving example after example that we've cataloged, and just because you've seen it here, it may or may not work for you. But obviously, with the breadth of our work, we're finding different techniques. Well, now it's time, remember I said it's time to go to the field and make sure it works. So we then do what we called the park bench decompression. He could only walk 3 or 4 minutes before those back symptoms started and the pains down his legs. So we said, go walk in a park with a park bench. If the pain starts every 4 minutes, you stop at 3. Don't pick the scab and don't cause pain. But go over to the back of the park bench, put your hands on the back of the bench, lean up over the bench, and just remember the little anti-shrug I was showing you? And now watch my hips. I'm going to let my hips drift towards the park bench. Stay there for 30 seconds. And he stood up. He says, Doc, yep, my symptoms are gone. Great. Go walk another 3 minutes. Come back and you cycle it. Now for the first time, instead of only walking 3 minutes and then having to give up, cumulatively, he walked 15 pain-free. So you're starting to get this idea of cumulative training for success. Short, little exposures. Gain success that way. And slowly, that envelope, instead of breaking to pain in 4 minutes, it's now 8 minutes and 10. look, our job is to keep what we have as long as we can, right? We don't want any more. Just don't take any more away. So there's a few thoughts. Well, I thought I'd finish with something. I heard back pain cells. So I know there's a few docs in here. Every clinician will tell you that they have patients who come to them and say, the last time, well, we're now abstinent. We haven't had sex for half a year because the last time we did, we knackered our back so badly that we're now fearful. I think I know what image just went through your mind. And nonetheless, our research program for the last 32 years, we were never interested in little questions. We always went to the clinical community and said, what's the biggest problem that you need the solution to? And it came around that it was time that we looked at that one. There are no clinical guidelines that exist to guide clinicians now to tell patients how not to knacker their back doing having sex. So we said, let's do it. It took us a very brave student of mine, one of my graduate students. Well, you can laugh, but I'm being very serious now. Her name's Natalie Sidorkowitz, and she has created the first atlas that you can now, we give it out to physicians. So when that patient comes and says, we're so fearful, we're now abstinent, the clinician now measures their pain trigger in terms of offending motions, postures, and loads, and shows them on the chart what not to do and what to do. This was the most successful media launch campaign in the history of the university. We made The Economist broke back mounting sex and backache. We were on the front page of Costa Rica, Italy, France, China. We touched 1.4 billion people in the readership of that. We didn't make the front page in the US. Well, you can say, you live in an awfully interesting country. There's no university in your country that would be allowed to do this research. They'd be shut down. So now the Kinsey Institute, which is the repository in Indiana of sexual health science, who can't do this research here in the US, we've partnered with them. And if you want to volunteer, no, I'm only kidding. Anyway, I'll just wrap this up by saying some of you have been dismissed. You have back pain, it's because you're getting older, it's in your head, or you've got, back pain has a reason. Get a diagnosis, and if you can't...
Would mattresses make a difference?
I'll take questions at the end, sorry. But get a precise diagnosis so that you will know exactly what to do and not do. Then you can wind down your pain trigger sensitivity and build a pain-free foundation. Now you've been empowered. Good clinicians show the patient how to cure themselves. Good clinicians and coaches don't create movement fear and avoidance and tell them they have a disease when they do not. They create movement confidence and competence. And that was the great gift that we learned from the Pensacola firefighters. There is a time for surgery, but I can now also give you a statistic because we follow up with every single patient that ever has come to our clinic. There are those who've been told, well, you've tried physio, chiro, we've sent you to the pain clinic, you've seen the orthopedic surgeon, the only thing left for you is surgery. Of the 95% of those, we get them to avoid surgery. And the first thing we start is this. We perform virtual surgery. Virtual surgery is this. I'm very dramatic and I go up to them, I'll touch them on the shoulder and say, there, I bestow upon you surgery. Now, some people will say, I have to go to the gym every day and go spin on the elliptical machine for 20 minutes because if I don't, I'll get so stressed and I'll murder my husband. Or whatever it happens to be. They're addicted. And I'll say, but if you had surgery, it's forced rest. For the first time, you've stopped the pain triggers on your back. So There you go, you've had virtual surgery. Tomorrow, you're going to behave like a post-surgical patient. And you're going to do just a little bit as you would. And slowly, you will build it up, and lo and behold, you will beat your back pain. Try it. It will work in 95% of you. Well, Ken, Dr. Ford, thank you, sir. I get the diversity of the audience, and I appreciate the experience that's in here as well. So I hope there was a little bit of something in that talk for each of you, and I thank you very much for the honor of speaking. Okay, well, I guess our mic's and ready and waiting, so you can fire away. Michelle, I guess there's a question there.
Do you have a recommendation as to the best type of mattress to sleep on?
Well, I'll tell you what the science says, because no, I don't have a recommendation for you, but let me tell you what the science shows. Basically, they subcategorize people into what's called a square and a triangle. Now, looking at you, can we talk about you? Yeah, you're more of a triangle. So you're a woman with curves. You've got high shoulders, and so you, typically speaking, if you're on a very firm mattress because you're curvy, the parts that aren't supported are going to slink into the mattress, and it will deviate you. So you might be wiser to get a somewhat firm mattress, but have a pretty healthy pillow top on top. Now, having said that, I would tell you I would not go for one of those memory foam types of beds. Here's why. When you sink into the foam, that's it for the rest of the night. You would have to wake up and work to climb up out of the depression. Do you follow what I mean? So the memory foams tend to work better for the squares. The ones that just go and they lay there and that's it. They're not going to move. But anyway, there is what the science would show. But having said that, go to the mattress store and forget the world. Don't worry about the salesman. Tell them to go away. And you lay in that bed for an hour. And then you will know. So, there's a little bit of science with a modicum of just a bit of horse sense. Yeah. Sir, yeah, we'll let the mic come over.
Thank you for visiting Pensacola. The mineral manganese is essential for healthy tendons, ligaments, cartilage, and disc. And a lot of us think the American diet is anti-nerve, anti-blood vessel, and maybe even anti-tendon, ligament, cartilage, disc strength, or just constitution. Do you recommend at all supplementing with gelatin or manganese to strengthen the disc with your patients?
Well, the answer to that is, I don't know. It's out of my wheelhouse, so I really can't answer that. I stay within my wheelhouse of expertise, but it's a good question. Sherry, you want to, and I happen to know Sherry, and I don't know he did have to go anyway. Sherry and her husband John, John's at the Naval Academy, and I've been there for the last couple of days, and you've been fantastic hosts as well, so thanks so much. Sir?
Does acupuncture have any role in your world?
In my world?
Yeah.
No, I am not qualified, or I have zero skill in that. But I'll say something that is a bit more of a broader answer, if I may. My world is diagnosing the mechanical cause, getting rid of that mechanical cause, and then building the best performance and tuning the machine. I can think of several of your great Olympians in this country who I've seen as patients, and in the end, I've done all I can. I've got rid of their pain. They're back to training heavy. They're doing well, except they've got one little snag. And I can think of one in particular, one of your great Olympians, and in their QL, there was just a little snag, and I did not have the manual skill to get rid of it. But I do have my go-to gurus in what I call manual medicine. And they might be, dry needlers or acupuncturists or whatever. And 3 sessions with that person, and they made me look like a superstar. That was the last little final piece of the puzzle. I'm going to say one other thing as well. You may see on the infomercials these, guys that are selling, a little TENS machine or something like that. Well, there's one on the infomercials where I was asked to do a investigation for the report to your FDA to get it approved as a medical device. Is this thing for real? And what I learned there was from the consulting physician, it works better when you put it over acupuncture points. Now, I have zero expertise on that. I don't understand it, but that's all I can tell you. So again, to stay within the integrity of the science, that's all I can really say. So I don't know if that answers your question, but I'll leave it like that. Could we go here, Sherry, with this late? And then I see you, so maybe second, Michelle, please.
Thank you very much. How about inversion tables?
Well, again, I've measured inversion tables, which will elongate your spine and decompress the disc pressure to some degree. When you stand up, all of that decompression is gone within 15 minutes. So does it help some people? I can tell you that it's hurt some people. What I would do if a patient asked me that, I would say, look, let's go try it. Do you feel better or worse? Now, some might say, oh yeah, I feel better. No, I make it worse. Good. I'm going to restore the natural curves of your back first. I'm going to put a little lumbar pad under your low back. Maybe you have a lot of curve, maybe you have big buttocks, I don't know. But we're going to shape it a little bit to de-stress as much as we can. Then we're going to try it. But then I'm going to put them on a table, and then I'm going to try a little decompression, traction on them, and I'll play with the amount, I'll play with the angle. For example, if you have a femoral nerve root coming from L1, 2, and 3 that's a bit irritated, when you bend the knee, it pulls on the femoral root and causes the pain. So do you see, if you hung upside down and bent your knees, that would cause you to get worse. So it depends on what the offending pain mechanism is. It gives some people headaches. Anyway, do you see where I'm headed with this? It's like every single thing you're going to ask me, the answer is always, it depends. Understand your pain mechanism and pull out the best clinical tool you can find to address it. How's that for I'm not trying to avoid your question at all, but I have to stay, again, within the integrity of the science. Yeah.
Thank you. Very enjoyable. When you talked about your body repairing some of its gel or liquid, those kinds of things, is that a permanent fix if you continue to do your proper mechanics? Or if you slip out of it and fall back into your old sloppy ways, you're going to go back into hurting your body, and is it something that you can repair forever is what I'm asking. Is it going to repair itself and be that way forever, or every time you do it wrong? I
understand the question. The answer is yes and no. Generally speaking, well, look, I've got people with a disc bulge and a disc herniation playing in the NBA, the NFL, fighting in the UFC. So, yes, we can manage it to subclinical levels, no problem, for some of them. If they get out of position, yes, it will come back. Now, some people, it seals very quickly and starts to gristle, and it's better if you're older. But if you're younger, with a more viscous gel, it's a little harder to seal. It's going to take a bit more time, but eventually it will. So there's a little bit of an answer. The older you are, the faster it will seal, generally speaking. Does that help you? Oh, there's a great advantage to be getting a little older. You're going to grow out of that back pain.
Thank you for coming. There's been a lot of television, internet advertising in the U.S. this year about stand-up desks.
Yes.
Are they? Really, two questions: are they beneficial? And secondarily, I happen to sit at a computer at a desk quite a lot,
Yeah.
and I'm tall like you are. Is there something I should be doing specifically because of
Understand.
height and size?
Okay, well, there's two questions there. What about stand-up, sit-down desks? Well, here's the funny thing that we measured, and again, forgive me for folks, but it depends. Now, here's something very interesting. Does everyone know what lordosis is? Lordosis is the curve in your low back. Now, when we measure people with a lot of lordosis, they stand in what's called elastic stress. Now let me define first of all elastic equilibrium. It's a mechanical concept. If I could get anesthetized and fall into a swimming pool, my joints would go to elastic equilibrium. So if that's elastic equilibrium for my elbow, if I extend, I get flexor stress. If I flex, I get extensor stress. So do you see how that's my elastic equilibrium? Now, people with a lot of lordosis stand in elastic extension when we measure it. So when they sit down, they unstress their spine. If a person has a flat back, when they sit down, they get more stress because they go even more flat. Do you guys see the argument? So the scientific principle is based on elastic equilibrium, which is based on your anatomy. So do you see how, again, it depends, and the first thing I would look at is where your elastic equilibrium point is. But that's what the scientific mechanistic research shows. But the practical shows is that if you stand a lot, your relief from standing should be sit a while. If you sit a lot, your relief position is to stand for a while. So you don't stand all day and you don't sit all day. And that was the beauty of the sit-stand station. It's easy to adjust. So when you get tired of one, go to the other. That's the more simplistic route with the science on top of it. However, if you sit a lot, and I've noticed you a little bit in your posture, and I've been doing a little bit of an assessment for the last hour on you, Why don't you try this? Make a fist and put it across your back like that. Now, relax and lean back. Scoot your pelvis to the back of the seat pan a little bit more and put your hand there. Now, you've got a sore shoulder, right? Right sore shoulder? A little bit. Yeah. Try it with your other arm. That shoulder's too. You got it. That's a better shoulder, is it? Slightly better? Yeah, you got a rotator cuff on the right. I can see it, right? Anyway, watch. When you put that behind your back, did that make your back feel more comfortable? Yeah. So, when you're sitting at your computer, get a lumbar pad and put it in there. Now you've taken away the stress that accumulates to cause pain. Okay, so there's an assessment right away that I can see in you. Okay?
One last question.
Right here, yeah.
I have a question. I was always wondering, is it good to crack your back? And for me, it feels good. And I know that's I don't know.
Yeah, I don't know for you if it's a good thing, but I'll tell you one thing. When a patient sits down in front of me and they are self-manipulating, so they'll sit there in front of me telling me about their back pain and they grab their neck and then they sit there and that usually is an indicator that they are over-manipulating and they have reversed neurological perceptions. And what I mean by that is, if I took a joint and I bent it, that's called jujitsu. Most people don't like that. You submit. Some people love stretching the end range. And because your body has stretch receptors, and the more normal response is to say, that's a stretch, I don't like it. The stretch receptors is to take you back to equilibrium. So do you see some people get reversed perceptions and they keep stretching, getting a 20-minute spell of analgesia from the stretch receptor reflex. not realizing that that's the original pain trigger, and they keep picking the scab, so it feels good for 20 minutes. Stop it. Every time you feel like stretching, go lay on a table, lay down. Do you see what I mean? So again, it depends on where your neurology set point is right now and whether you're in that reverse perception. So it doesn't really answer your question, I know. I don't know, but I bet if I could work with you for a little bit, we'd converge a bit more on the answer. Anyway, we're getting time called.
And let's thank our speaker.